Good evening, everyone. Welcome to a special edition of the UT Southwestern Science Café. Today's program is a unique opportunity to share about a new COVID-19 prevalence study focused on North Texas. King, and I'm Director of Public Affairs here at UT Southwestern, and on behalf of our two institutions, UT Southwestern and Texas Health Resources, I'm so pleased you joined us tonight. Science Cafes are online conversations where our speakers take you on deep dives into science topics. The format is casual and interactive, and our speakers are both UT Southwestern faculty and invited special guests. This special episode of Science Cafe is a deep dive into a new study about COVID being conducted through a partnership with UT Southwestern and Texas Health Resources. The study is focused on prevalence of COVID in our two most counties in the region, Dallas and Tarrant Counties. Before we get started, I have a few technical points to quickly share. Keep your speakers on mute unless you'd like to ask a question. This will help with our audio clarity. Also, please use the chat feature to list any questions about the study you may have. We will call on audience members to ask their questions during the Q&A portion of the program. Finally, my public affairs colleague, Corey Tovian, will help with facilitating Q&A. Before we get started on our presentation, I'd like to provide brief introductions of our distinguished speakers. Our principal investigator, or our PI, of this study is Dr. Amit Singhal. He's Associate Professor of Medicine at UT Southwestern. Dr. Singhal has an MD and a Master of Science, and his area of expertise is hepatology, or the treatment of liver disease. Co-PI with him is Dr. Andrew Masica, who is Chief Medical Officer, Reliable Health, for Texas Health Resources. Dr. Masica has an MD and an MS in clinical innovation and is an internal medicine. We are also proud to say that he did his residency training here at UT Southwestern. Last but not least is our other study co-PI, Dr. Jasmine Tiro. Dr. Tiro has a PhD and Master of Public Health and serves as Associate Professor in the Department of Population and Data Sciences at UT Southwestern. Welcome to each of our study investigators. Dr. Masica, I'll let you get us started.
Okay, well, thank you, Jenny, for the introduction, and we appreciate the audience spending a portion of their Tuesday evening. If you're like a lot of us, we're running out of things to watch on Netflix, so glad we could provide this as an alternative. Could I have the first slide, please? Or are we going to start with the polling question?
No, I think...
No, Amy should be launching in just a second.
Okay, we'll go ahead with the next slide, please. Okay, great, thank you. So this map here, what I'm going to do is walk us through sort of a global status in terms of where things stand with COVID-19 infection, break it down to the US level, and then also give it some more local context. So today, America broke the 2.6 million total case barrier. We have more cases than any other country across the globe. And in spite of only being 4% of the total global population, we have 25% of the cases. So what this map here, this shows distribution of the cases across the United States. So just to give you a general orientation, the brighter colors, the orange and yellow, that indicates a higher number of cases. And this is prevalence, so it's number of cases per 100,000 per population of a given county. So you can see that the areas that we've been reading a lot about in the news, California, Arizona, Texas, Florida, have the darker, or I should say the brighter colors, the orange and the yellows. And you can see right there at the bottom of the map, you can see the outline of Texas, and you can see Dallas and Tarrant Counties right there in the North Texas region. Just even a few days ago, another presentation with this map, it was a darker orange. So just several days makes a difference in terms of the hue of the color And unfortunately, we seem to be headed towards the lighter shades and even approaching yellow as this continues to unfold over the next several weeks here. So that just gives you the U.S. orientation. Next slide, please. And total case growth and total case volume is one thing. One of the areas of concern really has to do with the rate of case growth. So this is the U.S. experience, and just to orient you to the graphic, the left-hand side of the graph indicates the total number of cases diagnosed in the U.S. On a given day, and then the x-axis is the month. The red line indicates the trend, and each bar graph represents the number of cases on an individual day. So the red bar also indicates the 7-day average. When this pandemic began, this was the case volume was largely concentrated on East Coast sites. So New York, New Jersey, Connecticut, that's where we saw that initial spike, and we all remember that period. Over the ensuing 2 months, we had a slow decline in case volume, and I think in many cases across the U.S. we let our guard down a bit. What has been the concerning trend has really developed over the past 3 weeks, where we see a continued spike in case growth rate to the point now that we're seeing levels that were higher even than in the April peak. And what's different about this is that these are not necessarily the population centers on the East Coast. This is the Sun Belt. So what you've been hearing about over the past few days, California, Arizona, Texas, Florida, that whole Sun Belt region, that's where we're having the case growth and what has led to a lot of the concern. And we'll break this down more locally in terms of the implications. So next slide, please. All right, so what does Texas look like? So this is a Texas map, and to orient you to the graphic on the left, the bubble size indicates the number of cases in a given county, and then just like the other map I showed, the shade indicates the prevalence of cases per 100,000 population. So again, just a few days ago, we were a lighter shade of orange than we are now. So we're Dallas and Tarrant County, you can see it right there in the North Texas region, are getting darker orange and headed towards the red in terms of their prevalence rate. So numbers, just to give you sort of a more human element for what these numbers mean. So that gray outline represents what we call a trauma service area, and that's how the state looks at hospital volumes, bed capacity, and a whole number of healthcare indicators. And just in terms of looking at the impact of this disease outside of the actual numbers. So on the date, the 27th, there were over 1,800 ER visits related to COVID, 607 COVID patients, more than 700 with a diagnosis. And then you can see the row on the bottom that indicates bed availability and ICU bed availability, and also the number of ventilators that we have. So that just reflects what is actually going on in terms of an impact. The other thing that we don't see is the impact on the economy, and we all know the disruption to our daily lives. So this same website also reports the number of unemployment claims that were filed since the beginning of March. In the 2 counties, Tarrant and Dallas County, well over 200,000 unemployment claims have been filed. So we just see the more human impact of this disease in addition to the raw numbers. Next slide, please. And this graphic here indicates the COVID-19 case trends through the last time we pulled this particular slide was June 24th. The left-hand axis indicates number of cases the aggregate number of cases, and the right axis is the case number of cases per day. That green dotted line that you see that tracks closely with the solid green line, that is the average case growth on a given date. And again, what you can see is that it is trending upward. So we now have well over 14,000 cases in the DFW area. And this, when I say DFW area, these are the 4 major counties of the DFW area. Everything that we've been reading about, this graphic captures it for the DFW area. But the other thing to remember is that the case volumes that you see here, that has a downstream impact on our health system. So a certain percentage of these patients will require hospitalization, and a subset of that group is going to require intensive care. So it's this type of explosive growth over time that can cause challenges with hospital capacity. And if you look at our trend, just overall in terms of number of cases since the beginning of June, the number of patients in the Dallas-Fort Worth area hospitalized for COVID-19 has more than doubled since June the 25th. So that is a number that from a health system perspective, we keep a very close eye on, and all our contingency planning is based on this growth rate. And it's the trajectory is something that we account for in our operational planning. If the current growth rate were to go unchecked for 3 to 4 more weeks, we would potentially have some significant capacity issues within the Dallas-Fort Worth area. So that's why we are not only watching this closely, but intervening where possible in terms of our preparation work and surge planning. Next slide, please. So what do we know about the population who has COVID-19? So we are seeing a differential impact on populations. So the red bars in each of these segments indicates the percentage of a population with a certain racial description or ethnicity who have been diagnosed with COVID. The blue bar represents that percentage, the portion of that population, or the portion of that race that constituted the population. So for instance, if you look at patients who identify as being of white race, they're approximately 60% of the population, but only 35% of the COVID cases. Black patients, they are 14% of the overall U.S. population, but 22% of the cases. Those who identify as having a Hispanic ethnicity, they are 22% of the U.S. population, but 35% of the COVID cases. So this, when you hear about the disease impacting populations differentially, these are where these data come from. Now, importantly, for the study methodology that Dr. Singhal will be talking about later, this particular slide was pulled from a paper that was just put out by the Center for Disease Control. Race and ethnicity was only reported accurately in less than 50% of the cases. So that is one of the, that's a basis for this study, is that there's still an information gap, and the reporting on that particular information is incomplete. So it's one of the things we hope to address. The other component that is notable as one reflects on the growth trends and tries to interpret those, the average age of cases diagnosed with COVID is shifting towards a younger population. So early on, older patients, those with multiple comorbidities, in many cases, nursing homes were affected. What we're seeing now is the age is shifted downward dramatically. So we're seeing younger patients. And in fact, in Dallas County, since June 1st, more than 50% of the new cases diagnosed with COVID were in the 20 to 39 age group. So that's sort of another unusual hallmark of this particular disease. So another element of the study will be really having a solid understanding of the population and particularly its local implications. Next slide, please. So in terms of what we know about the disease, there are the vaccine is still several months off, and there are no current reliable pharmacotherapies. There are some that are still on an investigational level. And so treating this disease really hinges upon core epidemiology, knowledge of who the disease impacts, public health interventions, and understanding the immune response. As of today, there still are very significant gaps in our knowledge in these areas, and that is specifically what we're hoping to address for this particular study. Next slide, please. Okay, and so when you have a challenging problem, you always want to collaborate with your partners in the community to help solve that complexity. And one manifestation of that has been the Southwestern Health Resources Partnership. So that is a regional health network that was formed in 2016 based on the collaboration between Southwestern Medical Center and Texas Health Resources. This particular study leverages the strengths of both organizations in terms of our personnel, expertise in care delivery and research, and also just our geographic span across North Texas. You can see the numbers there: 29 hospitals, more than 6,000 physicians, more than 650 points of access to care. And importantly, the partnership created an expanded network for medical education and collaborative research with a particular emphasis on this type of study, which really focuses on population and community health. So again, we have a challenging problem. This is exactly what the partnership was designed to address and really provides a strong rationale for our study. And we will have one polling question, and then I will turn it over to my colleague, Dr. Singhal. All right. So as a break from the slides, the audience poll question is as follows. What is the spacing recommendation for safe social distancing? You can see your options on the screen. 6 inches, 6 feet, 6 yards, or 6 meters. Okay, well, that is one piece of information that has gotten out to the general public, so I feel good about that. So we all got that right. Someone's very conservative, or a few of you are very conservative and went with the 6 yards. You're not wrong, but the minimum recommendation, I should say, is 6 feet. So thank you, and with that, I will turn it over to Dr. Singhal.
Thanks, Andy. That was great to hear. Amy, we can go to the next slide. Next slide. So, we've heard a lot about the numbers of people that have been impacted in the U.S. And in our Dallas-Fort Worth area. But I think that this is a disease, as it spreads, I think it's more and more likely that this will hit closer to home. And so I wanted to start before we dive into the study in terms of, do you know anyone who has had COVID or COVID-like illness? So the answers, the possibilities are yes, I know someone who tested positive for COVID. Yes, I know somebody who had symptoms, so suspected COVID, but couldn't get tested to prove it, or no. And I can tell you personally, this hit home recently when somebody I knew actually got tested positive for COVID. And this disease no longer turned into numbers, but turned into a disease that, my family and I had to quarantine for 2 weeks. Luckily, we tested negative, but it's really a disease that I think will, as we've seen the surge in Dallas, start to hit more and more close to home. So of the people on the call, we've seen 61% of people know somebody who's actually tested positive. Another 8% actually have somebody that likely tested positive, or would have tested positive if they got tested. So 70% of people know somebody who had COVID or COVID-like illness. And what I'm afraid of is, as this continues to spread, I think these numbers will only go up over time. And I think really informs the importance of the study that we're planning. Next slide. So, Andy did a great job of highlighting a lot of the data for the US as well as our North Texas region. But one of the things that I think we have to recognize is that there are notable limitations of all of the data that are available. So the first thing that we know is that there's a lack of widespread COVID testing availability. And this is starting to get better, but even though it's getting better, we know that there's still an underuse of testing in all settings, as well as here in Dallas and Tarrant counties. And the thing that we note is that it can actually differ by racial, ethnic, and socioeconomic groups. And so some of you may have seen the article in the Dallas Morning News that talked about testing being more available in northern areas of Dallas and Tarrant County than in southern areas, and being less available in areas of racial, ethnic minority and low socioeconomic status. And so the differential availability of COVID testing may impact our understanding of how many people are testing positive. I think some of you also may have seen these reports that actually many people may be asymptomatic. And so, for example, the CDC has said up to 30% of people may actually not have any symptoms when they're positive for COVID, and this may be even more likely in younger persons. And so this study that talked about this, used the iceberg analogy, that currently we only recognize the tip of the iceberg, whereas the majority of cases are actually hidden and completely unrecognized in current practice. And so this study suggested that we actually only recognize 1 in 7 And data out of other settings suggest that we only recognize 1 out of every 10. And so this is one of the things that we're hoping to address in our study. Next slide. So I think all of us are also aware that there are other prevalence studies that are ongoing in the United States. So I think that 2 of the most well-known studies that are actually looking at how common COVID is in a larger population have happened in New York and in California. But importantly, what these 2 studies did is that they invited people to participate by using this as, like, they would go out and they would offer testing in stores, or they would use other convenience sampling, like using social media. And those people who may have responded may not have been representative of the greater sample of people that lived in those areas. So if you oversampled people who were out during the pandemic, et cetera, you may overestimate the actual prevalence or the actual number of people who were infected or exposed to COVID. And so this is one of the things, as you'll see, we're trying to get a better estimate of how many people have been exposed and are actively infected here in Dallas and Tarrant counties. Andy already mentioned that race, ethnicity, and other demographics are missing from a lot of testing data. And so even though this has improved over time, we know that race, ethnicity, for example, is missing in over half of people. And I think most importantly, and I say this as a non-Texas native, I grew up in Michigan, moved here about a decade ago. I've become more and more cognizant that Texas is a little bit different than the rest of the US. And I think that this figure here highlights this best. There's Texas, and then there's everything else, not Texas. And so I think from our standpoint, it doesn't necessarily matter what the data show in the rest of the US. We want data that represents Texas, and we want data that represents what we're seeing in our local area. Next. As you'll see, one of the most important questions we're trying to highlight by our study or evaluate by our study is this differential effect in race ethnicities and why this may be differentially affecting racial ethnic minorities. So why is this affecting African Americans and Latinas more than non-racial ethnic minorities? And what is the intersection? What's the interplay between race, ethnicity, and socioeconomic status? So we know that race, ethnicity, and socioeconomic status actually interplay a lot with each other for many other diseases, but we don't know how this impacts someone's susceptibility to COVID, nor the severity of COVID. We don't know if this is a true biological difference, or if this is related to other, living situations and other behavioral differences between different race, ethnicities, and socioeconomic status. So, for example, having an essential job, having different living conditions, different air quality, different housing situations. Does this impact why we're seeing more cases and more severe cases in patients of racial ethnic minority status and low socioeconomic status? Next. So these are interesting data from the COVID impact study. So this is a study of nearly 7,000 people that was done over multiple states, including here in Texas. And you can take a look at some of the impacts that COVID has had on different groups. And so Andy talked about not only the number of people being hospitalized, but also, the human impact of this disease. And I think these data show the human impact of COVID-19, and so how this impacts racial ethnic minorities compared to non-Hispanic Caucasians. And you can see, for example, workplace closures, closing of public transportation, school closures, all impacted racial ethnic minorities, those blue bars and green bars, more than non-Hispanic Caucasians, the red bars. Furthermore, you can see that these racial ethnic minorities also felt higher economic insecurity and food insecurity during the times that we've had with COVID-19. And this may mean that Hispanics and African Americans may be less likely to work remotely, may be less likely to take sick leave, and they may feel increased pressure to work during times of exposure to COVID. And this, once again, may explain some of the differences we're seeing. Next slide. So with these questions and with these data in mind, we designed the DFW COVID-19 Prevalence Study, which is planned to launch later this, in the next couple of weeks. The DFW COVID Prevalence Study will answer several important questions in our mind. The first is how many Dallas and Tarrant County residents are currently infected with COVID? How many have antibodies suggesting infection in the past? What's the current infection rate as well as exposure in frontline workers? And we're not really focused here on medical personnel, but more so non-medical essential occupations. So for example, those people who have work in a grocery store, airline employees, big box stores. What's the exposure if you're in one of these essential jobs? Third, what's the socio-demographic, occupational, and behavioral factors that may be associated with current and past infection, as well as the, once again, association with different race, ethnicity, and socioeconomic statuses. These will all be answered in the next couple months when we take a look at the cross-sectional component, i.e. surveying and testing people at one time point. We are also going to follow people longitudinally. And what this means is follow and repeating the survey, repeating testing at 6 and 12 months. And we think that this will answer several important questions. The first is, as social distancing and other policies change, how many new COVID-19 infections do we see over time? The second is, of those people who had prior exposure, i.e. they had a positive antibody, what does that antibody mean? Can you be reinfected? Does the antibody provide protection where we actually may feel like you don't get reinfected, and do the antibody titers persist over time? Next. To answer these questions, we're going to survey and test 30,000 community people in both Dallas and Tarrant counties, and we're going to have equal representation across the racial, ethnic, and socioeconomic groups. We're also going to survey and test 14,000 people in non-medical high-risk occupations. Once again, those occupations that we already talked about: grocery store workers, big box store workers, people working in restaurants, airline industry, meat packing industry. And so we're going to test people that are, once again, on the front lines on a daily basis. We're going to do both PCR testing with a nasal swab as well as blood tests for the antibodies. This will both test current infection as well as prior infection or exposure to COVID in the past. The survey that we're going to do is going to be relatively short, but will assess several important factors: demographics, exposure risk factors, including occupations like we talked about, and behavioral risk factors, such as mask wearing and social distancing behaviors. So for my next slide, I actually wanted to ask one of the questions that we asked during our survey to see what people think here. How important do you think wearing a face mask is when outside and social distancing may be very difficult? Is this very important? All the way down to not important? Let's see what people think. I guess I answered too quickly, so I no longer see the answer choices. So 94% said very important, 3% somewhat important, and 2% basically haven't left the house. So I think that overall, I think we all agree that mask wearing is important. And so this is, once again, it goes along with the answer that we had for Andy's question. I think people realize that the definition of social distancing, people realize the importance of wearing a face mask, and hopefully this will help flatten the curve and will help prevent this from getting worse in the Dallas and Tarrant County. Next slide. So here you can see a schematic of how we're going to answer these important questions. So we're working with a group called Research Triangle Institute that will identify people in both counties by household. And so we will then mail a letter. So people will be invited for the study. And this actually is very important because this is how it's different than some of the other studies where they used volunteers. And the idea of this is by using this sampling strategy of inviting people This will actually allow us to have a representative sample for both Dallas and Tarrant counties. Once those people are identified, they'll complete a brief survey by web or phone. They'll be scheduled for testing, and we're going to have that testing done at an easy to access location. As we talked about, we're going to do both PCR for current infection as well as antibody tests for past. In parallel, we're going to do the high-risk occupations, where we work with businesses in both Dallas and Tarrant counties to identify people that are in those essential businesses, and we're going to do on-site testing for COVID-19 in those workplaces. We'll report results back to those persons who are tested. So we'll let them know their PCR and their antibody status. Anyone who's positive, we would call with their results. Those who are negative for both would receive a letter. And then we would follow a sample, as I talked about, to have retesting done at 6 and 12 months later. Once again, to answer those questions of how long the immunity lasts and how many people are newly infected over time. Next. One of the things that we are very cognizant about is that there's not enough testing sites in both Dallas and Tarrant counties. And so what we're planning to do is we're planning to build new testing sites to make this convenient for people to get the PCR and the antibody test completed. And so these will be simple tents that will allow the people to come in, people will be scheduled, and the actual visit to get tested would be very quick, very short, so you could come in, get tested, and leave very quickly. And we are also going to have mobile vans that will be available that can allow in-home testing for people that don't have transportation, maybe on quarantine, et cetera, that can't leave the home. Next. I think this is my last slide. I think, of course, I think everyone on the call realizes that time is of the essence. I think everyone here would like to know these data yesterday, as would I. And so one of the things that we've been very cognizant about is wrapping this study up as quickly as possible, and trying to get this in the field and trying to get all 45,000 people tested as quickly as possible. And so we have really set an aggressive timeline where the entire study will be completed prior to the end of the year. The other thing that we're planning to do, unlike most studies, is we are not waiting to the end of the study to let people know the results. We are planning to disseminate results to the community on a regular basis throughout the study. This study is not being done for UT Southwestern or THR. We really, as Jasmine will talk about, are doing this for, with the community and for the community. And one of the things that we are doing is feeding back the results in real time, so the community knows what the prevalence of COVID-19 is, so we can better figure out what we need to do to better address this and prevent these infections from getting worse over time. With that, I'm going to let Jasmine take us home. Oh no, I have one more slide. If you were invited to the study, would you be interested in participating? The options here are definitely yes, maybe, definitely not interested, and sure, why not? I take any excuse possible to leave the house these days. I'm really hoping I get a lot of definitely yeses. Not to bias the results here. %, 18% maybe, 2% not interested, 4% sure, why not? I'll take it. I'll take that as a win. Jasmine, I'll let you take it home from here.
Great. Thank you so much, all of you, for joining us this evening to talk about this important study. As you can imagine, doing a study of 45,000 individuals over the span of 3 to 4 months is an awesome undertaking. And it really requires community willingness to participate and respond to the call. I don't know about you, but I actually don't open my own mail for most part. I rely on my husband to triage my mail. And what we need is for people to understand the importance of this invitation to participate in the study. And we're doing that through community engagement. There are 4 major goals in our study that we are trying to accomplish. First, it is really important for us to have transparent communication of all of our study plans and activities. And we are doing this through communicating, like through this Science Cafe, our plans to community leaders and community members. It is also important for us to gather systematic feedback throughout the execution of this study to optimize our study recruitment processes, as well as make sure that our interim and final findings are reaching the populations who are interested in the information. Third, we want to motivate community members to participate if invited. This study is a population-based sample, and that means that people are randomly selected out of our total population. Unfortunately, we cannot recruit, invite, and test all 7.54 million individuals who live in the Dallas-Fort Worth metropolitan area. Instead, we're randomly selecting a subset of those, 45,000, to better understand the prevalence by taking an estimate of our sample and then generalizing it to the total population. The only way we can create precise estimates is if we randomly sample people from the population based on where they live. We're also going to ensure that findings are presented in ways that help policymakers and various community stakeholders make decisions that address their community needs, as well as help us better understand how health disparities are affecting different subgroups of our population. Next slide. We are doing this community engagement through several different investments. We have a community engagement team of over 10 individuals from UT Southwestern and Texas Health Resources who do day-to-day management and coordination of activities that are described in this slide, as well as hosting virtual webinars and the UT Southwestern Science Café that all of you are attending today. We have invited over 30 members to join our Community Advisory Board. These Community Advisory Board members represent diverse sectors, from the government, from public health agencies, from businesses that are essential, faith-based communities, not-for-profit organizations serving particular constituencies, educational institutions, people who are experienced in science communications to lay populations. And our Community Advisory Board will be meeting with us on a monthly basis to advise us on study recruitment, give us feedback on where we're locating our testing sites, as well as the best way to present our findings. We are also engaging in a formal media plan to continuously promote study activities to increase the likelihood that people have heard about our study. And we're doing that both through regular broadcast and newspaper media, as well as social media. Our study website, utsouthwestern.org/prevalence study, is our one-stop shop to learn about our study design, our recruitment plans, and our interim findings. And finally, we're engaging with several organizations, JBJ is one of them, to do grassroots engagement, connect with community influencers in different areas and neighborhoods around the Dallas and Tarrant County, distribute our marketing materials, and encourage participation. Next slide. This is just a list of our community leaders who have agreed to participate on our Community Advisory Board, and we thank them for their service and look forward to the feedback on how they're going to help us make the study stronger. Next slide. And on that note, I just want to thank you again for taking the time. Sometimes it feels like we're talking to the choir, right? Based on the answers that we heard from everyone on this call. I'm heartened to hear the number of people who are engaging in social distancing, who understand the importance of wearing masks, and understand the importance of investing in our community in doing these type of studies. This is not universal, and we need to make sure that the word gets out to other members of the community. And I hope you help us in doing that by sharing information about the study with your friends and family members and colleagues. And at that, I'll take questions. Corey?
Yeah, thank you guys. Thank you all the wonderful presenters. We are going to start, excuse me. We are going to start with questions. Our first questions that we are going to address are questions that were sent in advance to us. So I will go ahead and read those, and then I'll go to the live questions that you guys have been putting in the chat box. So our first question that was sent in is, will the study include questions about how well the protocols of distancing, masking, hygiene are followed? Dr. Singhal, can you answer that question for us?
Yeah, Corey, that's a great question. So I had mentioned the survey that we're doing prior to the testing, and that survey assesses several different components. And these behavioral components are one aspect of that survey. So we're asking people questions like, how important is social distancing? How important is wearing a mask? How often people do that? And what other exposures they may have, such as, once again, being an essential worker, having kids in different environments. And so we try to assess all of those different exposures, as well as different behaviors that they may be doing. And the plan is to then link those exposures to the results we're seeing in terms of positive antibodies as well as positive PCRs.
Great, thank you. Our next question that we received, I live in one of the most affected Dallas zip codes and 2 blocks from the worst zip. Why are some zip codes more vulnerable? Dr. Masaka, can you handle that?
Yeah, sure. So is interpreting that question, I think what is really being asked there is how does socioeconomic status contribute to risk of disease? And Dr. Singhal covered that very nicely. And it's really the things that track with socioeconomic status, which tends to correlate to zip code. So things like comorbidities, crowded living conditions, air quality, occupational exposure, access to care. So all those things seem to be correlate with an individual's risk of disease. So it's those are the factors that, in terms of trying to understand and better address those, that's how disease risk correlates to zip code and different markers of socioeconomic status.
Great, thank you. Our next question, are the numbers really accurate regarding African American and Latinx communities? Dr. Tiro?
I think if we're doing this study, then the answer to that question is we don't have enough information to know whether the numbers are accurate or not. Much of the data that we have is not local, and the information that we need to inform policy and inform what is happening and why our rates are increasing across the counties is to collect local data. And that's why we're powering our study, sampling at a household level across the 2 counties to make sure that we have good representation of all of the different race ethnic groups, as well as the different socioeconomic groups, so that we can really quantify how much the prevalence of COVID infection is affecting different subgroups in our population.
Great.
And the answer is not right now, but hopefully in 3 or 4 months, we'll get back to you and have much better and much more accurate numbers.
Great, thank you so much. Our next question, what can people do to help prevent the spread of COVID-19 in the groups with ethnic and socioeconomic disparities? Dr. Singhal?
Yeah, I think, great question. I think that, I think that the question is, what can we do to prevent the spread of COVID-19 in all communities? I think what we have to do is do the recommended behaviors like social distancing, wearing a mask whenever you're in public. And then I'd say, if you're feeling sick, to stay home. And this isn't, I can tell you, I have probably been one of those people in the past that, I have a mild cold, I'll just wear a mask or I'll just go out and I'll tough it out. This isn't the time to tough it out. So if you're not feeling well, I think it's the time to stay home until you know if you're infected or not. And then otherwise, I think social distancing, wearing a mask, I know it's tough. I can tell you, I'm starting to have cabin fever, and I imagine many of us are starting to have cabin fever. But I think it's really, what I'd say is this is the time where all of us have to, work together if we really want to make a dent in this disease.
Thank you so much. Our next question, what are the public policy implications of the knowledge you will gain from this study? And can you share theoretical examples? Dr. Tiro?
So one of the things I'm most excited about this study is the longitudinal component. In our coverage and daily reading of all of the different studies that are coming out, there's only been one study that has looked longitudinally at how long someone has been protected after having a COVID infection. And that's a study of 37 people in China. And what they found was that antibodies waned for those who only had asymptomatic infection, such that the number of antibodies they had circulating in their blood decreased after 2 to 3 months. What does that mean? Less antibodies means that maybe they're not protected for as long as we would expect in terms of other illnesses. And so our thoughts that if just enough people get infected, then everyone can stop having to social distance and we can go back to our normal lives. That information is critical for us to inform what we need to do locally in terms of how long we need to social distance. We know that social distance is a privilege, and Amit covered that very clearly. Social distancing is also a mental health burden. We as humans are social beings. We want to connect, we want to see each other, we want to have dinners together, and that is hard to do when we're trying to protect each other and not transmit infection. And so by having information about longitudinal data on how long people are protected, that can really help us explain to what are safe behaviors that we can engage in long term.
Great, and this is our last question from the advanced questions, and then I'm going to move on to those of you who've posted in the chat. When I do call on you, please go ahead and unmute yourself, turn your video on, and please feel free to ask any of our panelists the questions. But our last advanced question is, do you predict the control of COVID will mirror other eliminated corona family outbreaks or influenza that has seasonal return? Dr. Massa?
That is a very difficult question to answer, and it's one that I don't think anyone has clearly established an answer for. What I would say is that this pandemic has really sort of been an exercise in modeling and a demonstration of our ability to model population health and the impacts of specific diseases in terms of growth rates. I think we have a better understanding of that. What still is being determined is whether or not we're in the first wave, or this represents a second surge within the first wave. There's debate on that. The common point where people tend to converge on is that in the fall, when the normal flu season hits on top of the COVID pandemic, that could be significantly problematic from both a health and a healthcare system capacity standpoint. So again, a lot of us don't know the timing, but when you hear about the surge or the problems that are likely to happen in the fall, that's really one of the things they're worried about, is a concurrent flu pandemic on top of COVID. Plus, we still don't know things like the impact of children returning to school, groups where it's hard to socially distance, and other seasonal effects. So I think there's a lot that keeps us from being able to answer that question about exactly what will happen very accurately. So it's this whole disease has been an exercise in adaptation and applying new information as it's generated, just like we hope to do with this study.
Great, thank you so much. Now moving on to the questions that you guys have put into the chat. Our first question comes from David Tyler. David Tyler, did you want to go ahead and unmute yourself and ask our panelists your question?
Yes, thank you. Just a question about the demographic and wondered if Native American indigenous peoples would be one of the groups.
So in terms of the Dallas-Fort Worth population, less than 1% of our population is from indigenous tribes. And so part of the challenge of sampling from that population is needles in a haystack, right? Identifying and finding them and recruiting them to participate. And so they are classified separately and as per our census and the way in which we report on data. And so the data that you saw in that earlier, in those earlier slides was only representing African Americans, Latinx, and then non-Hispanic white populations. So they are represented disproportionately, and some of the best data that we have on that is from New Mexico. And we will definitely be learning information from that data in New Mexico, and hopefully we will also be able to contribute some of that information based on data from our study as well, and we'll keep you posted.
Thank you very much.
Unfortunately, just to follow up, I agree with everything that Jasmine said. In terms of that chart that Andy showed, it just unfortunately was not included in the data that they revealed, and that's why we couldn't present that specific subpopulation. But once again, hopefully we'll have more information coming out about that subpopulation over time.
And the base report was from the CDC. So if someone could, maybe we can cut and paste, and that's open to the public. So if we could cut and paste the link that is on the bottom of that slide, people can access that article directly.
Absolutely. And we can also send it to all of you tomorrow
Okay.
as part of the follow-up email as well.
Great.
Our next question comes from Valerie Wigglesworth. You had some questions?
Yeah, can you just talk about, and thank you, by the way, for all this great information, but can you talk about with the Fort County area being so tied together and people moving back and forth among the counties, why did you decide to focus on Dallas and Tarrant counties and leave out Collin and Denton?
Valerie, it's a great question in the sense of, our intent was not to leave out any counties or any individual people. We focused on Dallas and Tarrant counties initially because those currently are the two highest in this area, the two highest impacted counties in terms of absolute number of COVID-19 cases, and leverages, where UT Southwestern THR have the most ties, in the sense of, we have testing sites that have already been established that allows us to launch in a very short period of time. The hope is that as we continue to get data, that we will be able to expand the study in the future to evaluate other counties, Collin, Denton, obviously being two of the highest of interest. But we decided to focus on Dallas and Tarrant right now related to number of cases and our ability to get the study up and running as quickly as possible in hopes of providing data as soon as possible.
And we'll pick some of that population up also from the employment. Obviously, people, if you can also get tested via your employer. It doesn't exclude you if you live in another county if you're employed in Dallas and Tarrant counties. That would be another potential pathway for people in other counties to participate.
The two other things I would add are that 63%, or almost 2/3 of our total population in the Dallas-Fort Worth area live in Dallas and Tarrant counties. So the majority of our population lives in Dallas and Tarrant counties. And they also are the two counties that are the most densely populated in terms of their living conditions. And one of crowded living conditions is a major hypothesis for why there is spread of COVID that is causing increases, and we can quantify that potential hypothesis via our study. And it's really important to have that information to help inform policymaking.
Great, thank you. Our next question comes from Bernardo Castaneda.
I can take that one.
Okay. Hey, thanks guys for actually participating and providing all this great information. I think it's actually going to be very beneficial for not only, across everyone, but also the minorities that are going to be impacted. One big question that's running around right now is who is actually protected while using PPE? Is it the person that wears the mask or the person that is not wearing the mask but is in conversation with someone that is wearing that mask?
Yeah, so I can take the first effort at that one. So what the mask does is the mask prevents the person who is wearing it from transmitting respiratory particles to another person. And so the idea is that if two people are wearing masks and would be in proximity to each other, you're preventing either person from spreading those respiratory particles. There's also a subtle difference in terms of the types of masks. So the masks that we're encouraging for the general public just when they go out would be a mask. What those masks are doing are preventing transmission of those particles. There are special masks recommended for higher risk situations or healthcare workers called N95 masks those are more effective at filtering out particles for the wearer, but they're less effective in terms of preventing transmission from the wearer to outside of the mask. So it depends on the nature of the situation, what you're doing, but in general, what the masks do, the standard mask that most of the public would be wearing, it's preventing transmission of respiratory droplets to another person. And so that's why the recommendation is for everyone to wear it. And so that's part of it in terms of, well, I'll take the risk of not wearing a mask. The problem is that if you're doing that, you're creating a risk to others, not necessarily yourself. So that's been one of the challenging aspects of this.
Great. Thank you so much. Our next question comes from Juan Nunez. Juan Nunez, you had a question for our panelists?
Yes, I do. First, I want to say this is a very exciting project, and it also seems like it'll bring a direct good to the community. My question is regarding the undocumented community in DFW. Will they be factored in, and also what are the protections offered because any positive test, I'm assuming, has to be reported to both local or to the state government. So,
I guess I could take first pass at this, and then Jasmine, Andy, if you have anything to add, great to hear your thoughts. So thank you for hearing about your excitement about the study, and to your question. And we are using an address-based sampling strategy, and so this is agnostic to being documented or undocumented, in the sense that we are going to offer the free COVID testing and the survey to anyone who lives in Dallas and Tarrant Counties. We are going to collect information in terms of offering that test, so obviously name, address. We are not collecting other information in terms of documented versus undocumented. That's not part of the intent. And so to your question of, working with our Dallas County and Tarrant County Human Health Services in the state, you're right that we have to report positive infections, and that's really with the idea of contact tracing. And so we have, Jasmine talked about our community engagement and working with members as part of the community advisory board. And one of the things that we're really doing is working with those people to make sure that we can do that contact tracing to help spread to help prevent the spread of COVID-19 without really talking about documented or undocumented. That's not the intent of this. So we will limit the amount of information we share, so that is not a concern.
Thank you.
Jasmine, Andy, anything to add on that?
No, I think you handled. That's the answers to the question. It is very important for us to make sure that we do contact tracing, right? To help make sure that we limit the spread of COVID, and that's our responsibility, and the public health agency's responsibility is to contact all friends and family workers and colleagues who come into close contact.
And that's also why we're calling everyone with a positive result. So the intent of the study is to call everyone. I know this is tangential to the question, but I think it's important that we are calling everyone with a positive result within 1 day, to really make sure that they know as soon as possible, and we are reporting results in a timely manner, so we can really have people quarantined, to really, once again, flatten the curve here in both counties.
Thank you. Our next question comes from Laura McCarthy. Laura, you had a question? I'll give her just a second to see if she can get unmuted.
Can you hear me?
Yes, we can now.
Hello, I'm excited about the work that you're doing. Thank you so much. I'm mostly excited that you'll be releasing the data as you get it in real time. That's excellent. If a study participant tests positive for COVID, will the study offer further guidance or support for these persons, or will they be left to their own resources?
They will not be left to their own resources. The idea is, once again, that we're going to call everyone within 1 day to make sure, and we provide guidance on that call, and that's why we're calling them instead of just leaving a voicemail or just sending a letter or some other means. We really want to make sure that when somebody tests positive, that we give them that guidance, that we talk about, once again, measures for quarantining if somebody's feeling well. If somebody is not feeling well, then we can help direct them to medical care as needed. And then also working with Dallas County and Tarrant County Human Health and Services to do contact tracing for anyone else who may have been exposed around them, including family members, close friends, co-workers, etc., to make sure those people are tested and also equally quarantined or directed to care as needed.
I think
But I think that, Andy started off, Andy started off by saying that, UT Southwestern and THR are two of the largest healthcare organizations in both of these counties. And, we talked about that's why we focused on Dallas and Tarrant to start with, or one of the reasons. And I think both institutions are ready to step up and help those people that are identified through the study, if they test positive. So I think, to your question, by no stretch is anyone going to be left to their own resources. Jasmine.
The one other thing I want to add is that our community advisory board is extremely well connected in terms of understanding what resources are available at the local level in all of our neighborhoods. And it's through knowledge of that information from our community advisory board, as well as our network of community influencers, that we'll be able to connect individuals with resources as needed. And that is, I've learned so much of all of the commitment that different non-for-profit organizations have made all across our Metroplex. And it's been really exciting to see how the community has come together to help those affected by the COVID pandemic. And so we're really excited to have a better sense of how our community is coming together and how we're helping each other during this time of need.
Our next question comes from Rebecca Botten.
Thank you. I think my question was actually answered already by Dr. Singhal in the chat. It was just a question related to if you would be keeping track of people's travel. And the answer was yes. Thank you.
Yeah, Rebecca, I'm just gonna, thank you for asking the question. We are collecting that as part of the survey. I think one of the other parts that came out in the chat that I do think is interesting, when we designed the survey, Dallas was not as big a hotspot as some of the other areas of the country. And so, we designed this and we thought we were being like really insightful in terms of, oh, did you travel to New York? Did you travel to New Orleans? Did you travel to Michigan, wherever? Now with Dallas and Tarrant counties becoming more of a hotspot, I know one of the questions was, why are you even assessing that since COVID is here? And that may be true. And I think that's going to be one of the other things that will be interesting, is because even though the study is going to be done quickly, we'll have to see secular trends of how this changes. As COVID becomes more and more common here, does travel become less important? And so we're assessing it as, I forget who, somebody else brought up, it may be less relevant now that COVID is here and in our backyard.
Yeah, I think that's the point. Just to add on that, I think the community behavior, certainly at this stage, what you're doing out in your community are probably going to have generate more risk than travel. Just from a pragmatic standpoint, there's not many places you can get to as you would in normal summer. So
yeah, outside of Houston. Houston's doing worse than Dallas.
Thank you.
Great. Our next question comes from Norma Garcia Lopez. Norma, are you still with us? Okay. Moving on to our next question.
Can I answer the question though, just for everyone else?
Absolutely, please.
So Norma was asking about how community engaged individuals can get involved in the study. And so while our household population-based study, you have to wait to be invited, or you have to be an employee of one of our occupation-based samples. We would love for you to help us be a community influencer and raise awareness about this study and share information about the study with your friends, families, and colleagues. Go to the website, as well as potentially reach out to us via the chat to volunteer and be a part of our community influencing network. We welcome all help because, as I said, recruiting 44,000 people in less than 4 months is not for the faint of heart.
And Jasmine, I know that, Grace Barber had asked a similar question of how can we help you as a research team? And I would just echo what Jasmine said. I think that, what we're hoping for, we saved 44,000 in 4 months. I mean, yes, that's like our quote unquote deadline, but I think all of us would love it if we could get everyone done in 2 months. So, if we can really get the excitement up and people responding quickly, the more data we get, particularly because we're going to feed back the data to community real time, the more numbers we get early on, the more data we get early on, the more we'll realize and the more we can act on this as we go along. So the more we have people know about the study, if anyone gets invited, encourage them to respond. I think that would be incredible.
Yeah, and I would just add on that again, a major tool we have in fighting this disease is accurate, credible, and timely information that we can use to shape our policies and our public health recommendations. So it is completely aligned with those concepts.
It's like G.I. Joe, right? Knowing is half the battle.
Absolutely. Our next question comes from Dorothy Mundy. Dorothy, you had a question? I'll give her a second. Okay.
What was the question, Corey? We can probably answer it just for others.
Absolutely. I am unfortunately having a little bit of a problem with my cat.
So I can read it. It's basically she asked if she was following up to see for those who were infected, if you could determine if they have protection. So basically the immunity status related to that.
And the idea is that we will be collecting that information in the sense of the longitudinal component will be following people that have a positive antibody to see the risk of reinfection, as well as assessing titers over time to see how long the immunity may last. So, I think that we're in parallel with the study, we're starting to have more and more information, understanding what the antibodies mean and how to interpret them best. But we are following those people and we should have information for the community.
Great, thank you. So this will be our last question, and it is coming from Nellie. Nellie, do you have a question for our panelists? I'm not sure if Nellie had to sign off.
Nellie said her network is no longer functioning.
Okay, well that is too bad.
Well, there might be one last question that's good from Gary Kaufman. I think that would be just relevant if we just want to touch on that one.
That would be great.
Design.
Yeah. So Gary asked, how will you account for those people who are contacted but refuse to participate? Will they be replaced with other people to try to keep your total participants maximized, or will you not replace the refusers? We will replace them. So the idea is that we will have 30,000 people from the community and 14,000 people from those high-risk occupations. And so if people refuse, we are going to replace them and get the numbers up to that level. Our idea is to really test as many people as we can to get the accurate data to inform.
And we do that by sending the invitations out in waves. So it's not, we don't select to replace them. It's just you send it out in sequential waves of invites with the expectation that a certain percentage will participate.
And Corey, can I do one more question if that's okay? I don't know, I forget who asked it. There was a question about accuracy, and I think it's just important because, there's been a lot of information, and this is so quickly evolving in terms of how much should we trust data, how much should we trust recommendations, how much should we trust these labs? I mean, we know that there were many labs that unfortunately came to market. Not all of them were equally accurate. And I can tell you that UT Southwestern THR were extremely thoughtful in terms of which lab we should use. And so our antibody and PCR test that we are using has 99% accuracy. And that has not only been validated externally, but that has been validated inside our own lab using the people that we have had admitted to our health systems. So we feel very confident that the results we will be giving you will be accurate. And I think, thinking about some of the other studies that have gone on, once again, one of the advantages we feel that we have, because we were going into this extremely thoughtful about what test we wanted to use.
Dr. Singhal, that was a really great way to end tonight's conversation. Thank you. Thank you, Dr. Massica. Thank you, Dr. Chiro, for our deep dive into our new joint COVID-19 prevalence study. We've received a lot of private comments that folks are excited about this, so I just wanted to share that. Corey, thanks for keeping us on track and moderating our Q&A. And to all of our guests who are still with us, thank you for joining us. We hope you enjoyed tonight's special episode of our cafe. I think we shared this. We will send you an email tomorrow with the survey, with the study link. And if you have any questions, email us at UT Southwestern. What is our email address, Corey?
Public Affairs at utsouthwestern.edu.
Yes, sorry guys, it's almost 8:15. We do have a science cafe next Thursday, July 9th. It's going to be one of our regular nights. It's going to feature Dr. Baron Sumer, and it's going to cover the science behind one of the new companies that was formed from cancer tumor research conducted here at UT Southwestern. So we'll be sending you information about that. We think it's going to be really cool. We're calling it the science behind sending a FedEx to your tumor. So just think about that. As we close out our cafe, please wear your masks. We've talked about that a lot tonight. It's very important. Maintain physical distance when you're out in group situations, and even when you're at home this weekend for the 4th. My family's coming in from out of town, and we're going to all be distancing in my house. And then wear your masks again in public, and let's work together to move North Texas back to better health. On behalf of UT Southwestern and our partner, Texas Health Resources, thanks again. Y'all have a good evening, and happy 4th of July.